Welcome back to the MediMobile Podcast. I'm Emily, here to introduce today's topic, all things MIPS measures. Here today, we have Morgan, our Vice President of RCM, and Lauren, our Director of Business Development, to lead a conversation on MIPS measures. Let's head over to them now.
Thank you, Emily. Today on the MediMobile Podcast, we have Morgan Krull, our Vice President of Revenue Cycle Management, here with us to talk about MIPS.
Hello. MediMobile does do and has a comprehensive MIPS program for any of the clients who want to participate or are eligible or required to participate.
So, Morgan, can you tell us exactly what the MIPS program is?
Sure. So the MIPS program came out of the MACRA Act of 2015. So prior to 2015, Medicare was doing a lot of these value-based programs, but they didn't have a general umbrella that they went under, right? So they had meaningful use and they had PQRS and they had something called the UVB, but they didn't have kind of a general overriding umbrella. So MACRA wanted that to happen. So the MACRA Act created that and it created the MIPS program. So now as a result of that, you have 4 components to the program, right? So you have, and that handles like meaningful use is now become what is called promoting interoperability in the MIPS program. The PQRS, which was a separate program, now becomes the quality component of the program. And then the 2 other components of the program are improvement activities and cost. And we can talk about those in greater detail. So basically the MIPS program was created, and as were those prior programs, to try to assess the providers providing care and the cost associated with the care and create a mechanism to pay providers appropriately for their quality of care.
So, and Morgan, you mentioned it, MIPS is very complicated, and my knowledge of MIPS I've definitely learned from working with you, so thank you for that. But how exactly does MediMobile support our new users in understanding and ensuring that they're meeting those MIPS requirements without being overwhelmed with all of the information it takes to understand MIPS?
Absolutely. So because of the complexity, and it is by nature a complex program, right? The largest component of the MIPS program is the quality component. And so our providers, by and large, are facility-based providers and hospital-based providers, right? By and large. And so and small practices. And so a lot of those providers are only required to participate in 3 components of the program. And the way that we support them, so quality is by far the largest component of the program. And quality is what we find that a lot of our providers have the most confusion about. There's a huge number of measures that you pick for quality. And basically what quality is, you track and you answer, you have the quality measures. There are many, many quality measures, and they're set to look at eligible populations for those measures based on the ICD-10 and the CPT that you bill. So a lot of new providers we work with, they see all these quality measures and they're super excited. And they're like, oh, I do see that population. I see this population. The problem with it is the measure themselves, because they are contingent on the CPT, most of the quality measures actually are not eligible for hospital and facility-based providers because they're based for outpatient measures. So what we do in our infrastructure in getting a provider introduced to the MIPS program and trying to ensure their success is we basically, every year when they issue the new program, we go through and we sub-segment the measures based on the scope of practice. Then when we get a new practice and we get a new client, we then go through their eligible measures with them for quality, as well as the same kind of replication for improvement activities. And we kind of discuss cost as well, the things they can do to optimize cost. But for quality, we help them pick measures that are actually appropriate to their scope of practice.
So when we've been on calls and I've heard you talk with customers, I hear you kind of analyze their process and everything that is occurring within their business currently. How do you think that sets us apart from possibly other organizations that are supporting MIPS?
So I feel like much like just the general charge capture and the AI and all that, we're building a relationship with them. So it's not just, I'm going to present you this data, here are your measures, and then we're going to give you reports 4 times a year. We actually try to engage and have meetings. We discuss, we review their data, because, and we'll talk about how they get the data into our system. And then we schedule meetings with them to go over what we're seeing in the data if they're not doing as well as they potentially could. So we very much try to build a relationship with them, and then we support them throughout. And they know us, and they feel like they can reach out to us if they have any kind of problem. Now, I can't speak to the other companies, but I know with some of the providers that we currently have clientele with, they moved to MediMobile for the charge capture, but they also had concerns about their prior MIPS companies. And that's one thing we did here, is just maybe not as the strength of partnership that we try to create at MediMobile.
Well, and I can definitely say I was on a call recently with Morgan and one of her other team members and a customer. And within just a few minutes, Morgan was able to make recommendations. And of course, that excited the customer because there were things missing from their business that Morgan was able to identify and help them with. So Morgan, you're amazing, as is your team. So thank you.
Oh, back at you guys all. I would say it is a complex program, but I do believe that a lot of our providers that were, if it helps, they were very concerned or trepidatious because it is complex. Most of our providers, I would say, I think it was 90%. Now, there's been a lot of exceptions due to first COVID and then now the Change Healthcare breach. But the ones that we do have, they're considered exceptional performers. And so as we talk about how financially it impacts the provider, one thing that I love is we've built these relationships and we work with them, and they're getting to see the financial impact in their practice.
Yes. So what is the process like to report the MIPS measures?
So in our process, when we contract for MIPS, so the MIPS comes out once a year and we adjust it, and we work with our engineering department, and they build off of the quality, off of improvement. They build what they call a rules engine, which houses the data in real time as the provider builds. So like I said, for quality is based off of patient age, certain diagnoses build, and certain CPTs builds. So what happens when the provider comes in, we help them pick their measures, and then we turn on their measures within the charge capture system. So what happens is they don't have to manually keep up with anything. The rules are built based off of each measure. Our engineers build them. So when they're doing charge capture, if the patient that they're entering meets the ICD-10 and CPT component and the age, they're going to get a set of questions that lets them answer their MIPS and lets them report their MIPS in real time. And then we aggregate the data so they don't have to do anything except for answer those questions during charge capture.
So for the providers, you mentioned that we make it a lot easier with our charge capture system. They're just answering the questions. And then, of course, with Genesis being rolled out, as long as it's in the documentation, our AI will actually pick up and record those measures. How exactly do you feel that reporting the MIPS can impact clinicians as well as their practices?
Well, so there is an impact. So a lot of providers around it is that there's a regulatory requirement, right? And so if you're required to report, and the way that the QPP, which is the oversight of the MIPS, they're the regulatory agency oversees MIPS. If you will be required to report if you're not a qualified participant in an APM, those are known as QPPs. So if you're not part of an APM, be required to report if you meet what they call the low volume threshold. So if you see 200 Medicare Part B patients, you bill at least $90,000 in the performance period. So for the whole year, 2 Medicare Part B, and you have at least 200 encounters, then you're required to report. So let's say they are required to report, because a lot of, especially hospital-based, you're going to probably see, if you're working even 32 out, part-time, there's a good chance you're billing $90,000 in charges. You're going to see 200 Medicare patients, you're going to bill 200 encounters. So the impact, though, if you're required to report and you don't, flat out, you take a 9% penalty. The way the MIPS works, it's a rolling 2-year financial impact. So what is done in 2024, they're going to see in their payments in 2026. So what that means is, let's say if you do not participate at all and you're required to report and you're not part of an APM, you choose not to participate, in 2026, you're taking a 9% penalty off of every Medicare encounter that you see. So it can have a severe impact on your practice financially, converse to that, if you participate, you can get up to a 9% positive payment adjustment. So we have multiple providers right now, and some of them are our billing clients, where they're making 7% higher on every single Medicare encounter above the fee schedule. So it's completely, and we have a lot of exceptional performers. And then a lot of our clients that are not our current billing clients, but they work with us in the MIPS program and have for years, they're telling us they're seeing a really good return. So it is well worth, it's a lot of work, but it's well worth doing it. And I do give Medicare that, or the QPP and Medicare, that they are offering that financial incentive, because they're kind of requiring you to participate.
Okay. Well, that's fantastic. So like Morgan said, we're seeing customers that they're not only meeting the requirements of the government, but they're seeing an increase in revenue due to
significant, because their hospital-based see a ton, or they see a large proportion of Medicare patients. And so very good. Yeah. And so a lot of them, it's a program that, and they, doctors have a lot of administrative responsibilities and a lot of clinical. So a lot of them, I understand they get frustrated with the MIPS program, but we do see the positive financial outcome if you choose and can participate.
Well, and just to add, one thing that we do see with some of our customers is in certain situations, possibly on different platforms, they can bypass the MIPS questions. But in our system, the providers, based off of the criteria, if they trigger those MIPS questions, they do have to answer the questions before completing their bill, which we hear a lot of times from organization executives as well as billing teams. That's very helpful because they don't have to go back and complete that work.
That if you are allowing them to skip, so there are guidelines within the quality component of the program. You have to have at least at a baseline 70% data completeness. So if you're allowing them to skip, you're putting actually that practice at risk. They need to be answering on every qualified, because ultimately the provider is held accountable for that. And it's also regardless of payment, regardless of coverage. It could be self-pay patients, charity pay. You're 75% data completeness. So to me, from a MIPS perspective, that's a liability for that provider if they're not answering on all the eligible populations. Because if they get audited and they request the records from the QPP does audits, and if they don't have that representative, it could be a potential issue for them.
Okay, that's great information to have. How does MediMobile specifically support reporting those MIPS measures?
So again, we have a very robust reporting system that the engineers have built. So as they enter their charge capture, right, they're entering. The engineers have built a system, a data warehouse to house. It calculates what their scores are, and it aggregates it. And then what we do, we try to do it quarterly, depending on when the provider signed on. We do ad hoc reports as well if they request it, but we generate quarterly reports of what their compliance status is along the measures, the quality measures they've had. And then we also, the engineering department has created a very detailed report down to the patient level of who's been performing, who's not performed. And that allows the providers we then meet with the providers. That allows the providers to review their records, see if the activities were done, and course correct before we have to turn the data in at the end of the year.
Oh, fantastic.
Yes. And so cohesive program for them. And we get a lot of that. So we do that quarterly. We just finished, we also do it at the end of the year to give them a chance. So we just finished October and sent them the reports, and we've met with some of them.
Fantastic. So when working with our team, if y'all are seeing any flags or anything, y'all are able to go back to the practice and they can correct that before it's too late. Is that what I'm hearing?
So we're seeing if we see outliers, for the larger groups, we typically meet with the administration, and we usually meet with the owners, but we're able to tell them, hey, I think this particular, let's say we have a group of 50 providers and 2 of the providers are struggling, and we can see it in the data, right? So we can take that data. Emily and I, who is also my other MIPS director, we will analyze that data. Then we set up meetings for the groups to say, okay, this provider may not understand the documentation requirements of the measure, or they may be answering it wrong, not understanding the activity is actually being done. So it allows us to also create the partnership with the administration and sometimes with the doctor, but it also is a consistency in the communication. And a lot of times the years they have the same measure. So we see these providers who may struggle last year are doing great this year. So the reporting to me is fundamental because it allows us to analyze and see if there is typically a provider who doesn't maybe understand the documentation requirements, or maybe doesn't understand that some of the measures are built that they're not actually doing the activity. They need to just document that they've reviewed the activity was done. So it's very important. The reporting is extremely important because it allows us to maintain that relationship and help optimize their outcomes for MIPS.
Okay, Morgan, how does MediMobile ensure the accuracy and completeness of the data reported for those MIPS measures?
So again, we go back to the reporting. We also have separate reports that engineering has built for us where we're comparing, because like I said, you have to have 75% data completeness, and that's across all patients, regardless of funding. There's always been a misnomer with some newer providers that they thought it was just Medicare patients. No, it's got to be complete across all patients. And so what we do is we take that, and then the providers have that, and then we audit it, and we work with a registry who audits charts to make sure that the compliance is there. So we have a comprehensive program, and then we have a separate organization that just turns our data in, but they also do sample audits of charts to see if the compliance is there. And at times, Emily and I will do the same if we have access to the medical records.
Oh, wow. Y'all really go above and beyond. So how do we help?
We work with medical records all the time with billing. So it's kind of good in a way. It's a very complementary relationship.
Great. So how do y'all help clinicians stay up to date with the evolving MIPS requirements, especially because there are annual updates to those measures and benchmarks?
Yes. So that's why every year, so it's a rolling year for us. So we keep in touch with all of our providers. A lot of our providers are doing so well now that we don't necessarily need to meet with them. So let's say I generated the last report, half of our providers were perfect. So we still send them the data, but they don't necessarily need to have interaction with us. But beginning of every performance period, which is next year, they're going to have some changes to the quality measures, changes to improvement activity. They're adding something called MIPS MVP program. They just issued the final rule on, so we're hoping some of our providers could use that. But we reach out to all of our MIPS providers and any providers that are interested, and we do a meeting once we know the changes and go through that with them, and kind of the same thing, building that relationship, helping them pick their measures, doing all of that on a yearly basis after the updates and the changes have been finalized. But the process is the same. It's keeping that communication and trying to assist our providers to optimize their score on a year-by-year basis.
Okay. Can you walk us through what a typical year looks like for a MediMobile MIPS program member?
Sure. So typically MIPS, they want you to collect your data from January to December. The QBP does, but the QBP doesn't always finalize the MIPS program, sometimes end of January and sometimes into February. So once they finalize that, we work with engineering to get all of the measures, the quality measure rules built and all of that. Then we meet with the providers, help them pick their measures, help them pick their improvement activities. And like I said, our hospital and facility based and small practices, they're exempt from promoting interoperability because they don't own their own EMR. So we don't focus on that. And then cost is something calculated by CMS. The doctors don't really do anything active there, except for I always advise them to try to code their diagnoses to the greatest specificity so that the patient can be in the correct DRG grouping. And because cost is risk adjustment based. But anyway, so we do that, and then we turn them on. And as they're doing their charge capture, we're aggregating that data. So once they have a contracted MIPS, anytime they see an eligible patient based on the measures that they've chosen, the ICD-10, the diagnosis for most of the measures, they're going to get a set of questions asked every time. If they choose to track by patient, they'll get it once per patient. They can also track by encounters. They can do it by encounter. And then that follows them throughout the whole performance period. So we're tracking continuously through December 31st.
So, Morgan, you pointed out all the benefits and the potential drawbacks by not reporting correctly, but why are there some healthcare professionals that choose not to participate?
Well, I will tell you, like, a frustration that I see a lot of inpatient, we're hoping they haven't given us the new measures in detail, But a lot of providers have frustration with the actual MIPS measures, meaning, like I said, there's roughly 490 MIPS measures, not quite that. And yet current year for inpatient providers, for hospital-based providers, there's roughly 9 that are applicable to them, because the history of MIPS was built around primary care and office-based. And so I think a lot of providers get frustrated, and we hear this a lot. Well, this is not applicable to my practice. And they have validity with that. But unfortunately, until we get new inpatient managers, if they choose not to participate and they're required to, they're going to take a huge financial hit in 2 years. So we try to buffer that a little bit by saying, we know that this, you're not, you don't really see a lot of dementia patients, but unfortunately that's one of the measures that is a hospital-based measure. And so, and I get the doctor's frustration, but that's kind of where I think that's kind of the challenge why a lot of them don't want to participate, because they feel like it's an administrative, I hate to say it like this, a hassle, and it's not really a lot of the measures available to them are not applicable to their practice.
So your team helps identify which measures are applicable.
Yes.
Okay,
so if you ever hear me in a meeting where I'm saying, what is your scope of practice? Do you go to nursing home? Do you do skilled? Do you have an office? Do you do assisted living? All of the reason I'm asking all of those things is because we then tie it back, because the measure specifications for quality, they have all of the CPT codes, and different places of service potentially, or actually they do have different CPT codes. And that's how we know how to help the provider optimize their measure choice.
We heard you talk earlier about the benefits financially for practices to participate, seeing that potential increase in revenue. Can you share any success stories where the MediMobile MIPS program has significantly improved a practice's livelihood?
I can. And so we've had several. So we've had several that had moved to MediMobile because they were with other companies where they were taking a penalty, right? And some of it was what we went back to. They were picking measures that were great, that were actually realistic to their practice, but they did not meet the CPT place of service. They weren't getting any volume, so they were getting penalized. And so those, now they went from having negative payment adjustments, meaning they were taking a penalty. And then in the first year, they had like a 3%, and now they're at a steady 7% positive payment adjustment. And we have multiple of those. And then we have some that have done great in quality and great in improvement activities, but we're struggling in the cost component. And so, but they're still getting a positive payment adjustment. And so we have quite a few.
So if there's anybody watching that's on the fence about participating in MIPS, what would you say to encourage them?
I would say first, look at your practice and see if you're even required to report. So if, let's say you're doing, I don't know, let me see, plastic surgery, and you're not going to have a ton of billing to Medicare, right? You're not going to see a ton of Medicare patients. You may not even be required to report. So I would start with, do I feel like I'm going to be required to report within the year? And if so, then do I want to take the risk of the impact of not reporting and taking a 9% hit off of my Medicare population? Or do I want to find a company I can partner with who can help me pick the measures that are available to me and optimize my outcomes so that at least I can either be budget neutral to the Medicare physician fee schedule, or actually have a positive payment adjustment? And it does, we see significance in those positive payment adjustments. They're significant. And but again, it is work, but those doctors are happy because they're seeing that positive payment adjustment. So at least they're getting something out of the program.
Well, and Morgan, correct me if I'm wrong, but if there's a practice that isn't sure if they're supposed to report or not, as long as they reach out to us, we can definitely clarify that for them.
Yes, we can tell them. And there is the challenge with eligibility that the way QPP has set it up, you have preemptive eligibility at the beginning of the year, because they determine the eligibility by 2 different segments of the year. So for 2024 to be eligible, you had to have been practicing and billing from October 1st of 2022 to September 30th of 2023, and then also October 1st of 2023 to September of 2024. So preemptive eligibility happens, and then they don't finalize the eligibility until November. So that's why I tell people, if you have a chance, we can check it for you. It's easy for us to see if you're current, if you're required to report. But they don't actually finalize the eligibility for the current year until the very end of the year. So that's why I tell people, when we really make a point of talking about the low volume threshold, if you think your practice is going to have $90,000 in charges billed in Part B, you're going to see 200 Medicare patients, and you're going to have 200 encounters, Medicare Part B encounters, and you're not part of an APM, alternative payment method, then you're going to be required to report. So that's what we try to tell people when they're on the fence, or if they're not required to report, we try to help them through that, because there are layers to that too. Some are required to report as a group if you choose to report as a group. Some are individual and group. It's based on your Medicare volume. But we definitely can tell them that, and then we go through that with them, because ultimately the providers know their practice. So if they don't think, because it is preemptive for most of the year, and the liability with that is, if you choose not to participate and then, oops, it turns out you've met the low volume threshold, you're going to be in serious trouble, because they tell us in November and the program closes out in December. So that's why we kind of try to really help the providers say, if you feel like you're going to meet any of this, you need to participate in the program, because you protect yourself throughout the year, so that if it does turn out in November, you're required to report, you have your data completeness met for the program.
Well, Morgan, thank you so much for sharing all of this valuable information. And like she said, if you're curious whether or not your practice does need to report for MIPS or is required to report for MIPS, you can definitely reach out to our team, and Morgan can clarify that for you. And as she stated, we have several happy customers that have seen an increase in revenue due to our MIPS program. So Morgan, thank you again for joining us today. And thank you everyone that joined us.
And yes, absolutely reach out to us. I think we've already had people starting for 2025. So they've just finalized the program, but I would say anybody who is ready to even just talk about the structure of the program, please reach out to MediMobile. We can help you and get you off to a great running start.
Thank you, Morgan.
Thank you, guys.
Thank you so much for joining us today, Lauren and Morgan. If you're listening and you'd like to ask any questions regarding our MIPS program, please reach out to sales@medimobile.com. If you're ready to book a demo and even see our automated medical coding solution, Genesis, head over to medimobile.com. You'll see a book a demo button right on the front of the website. Thank you so much.